Hello and welcome to this EAO Just Ask Live, your monthly live appointment with a leading expert in implantology. My name is Gerrit Heijkoop and I'm the host of this EAO channel, and in this live video session we're going to try to answer all your questions about the digital aspects of implant surgery. And for that I'm proud to be now really well connected and joined live from Israel by Tali Chackartchi. Tali, good evening.
Well, good evening, Gerrit. I'm happy to finally be connected and with you. I want to thank the EAO for the honorable invitation to spend this evening with you, and really looking forward to your questions.
Yes, exactly. You are an expert in periodontology. You have your own clinic in Tel Aviv. You're a staff member at the Hebrew University of Jerusalem and Hadassah. But more importantly, for the last 15 years already, you have been involved in the different aspects of digital surgery in implantology. And 15 years in this field is very long. So you are a real expert on this topic. Now, before we do a brief introduction on this topic tonight, I want to invite all our viewers who may have been part of the EAO Digital Days, or maybe those who have missed it, to I'd like to point out that all the videos of the EAO Digital Days are now available in the EAO online library, which is accessible for EAO members. Now, if you're not yet a member yet, know that if you sign up now, you get the last 2 months for 2020 for free. And you can access all this content directly. So if you haven't done so, do that now. Now, Tali, we are talking about digital implantology, and that seems to mean a lot to a lot of different people. So to set the shape of the discussion and to set the direction of the questions tonight, what are you talking about when you talk about digital aspects of implant surgery?
Well, Gerrit, you are definitely right. The digital dentistry or advanced technologies in implantology is a huge topic. So within the frame of the hour that we have, we will be focusing on computer-supported implant planning and guided surgery, especially how does these tools enhance our capabilities and make us improve our skills and knowledge.
Exactly.
So
go ahead.
Yeah. No,
well,
okay.
the key question is why? Eh? Why do we need this digital planning and the guided surgery? And I think you have prepared a few introductory slides for us, right?
Yes. So let me just share my screen with you. Okay.
Yeah, while you bring up your slides, let me quickly say hello to our viewers who have been responding in the chat. Frank Renoir is with us. Good evening, Frank. Good to see you as well. We see Mustafa Hussain greeting from Iraq. We have Christina Ivancheza from Bulgaria, always excited to be with us. Guillaume Heller, hello Tali. Philippe Breguin from France, hello. Paul Glick joining us from the Rocky Mountains in Colorado. So once again, we are connecting a truly international crowd tonight. So looking forward to your questions. But Tali, I see your slide is up. So tell us, why do we need this digital planning and the guided surgery?
Well, Gerrit, we can roughly divide the advantages of the digital tools to these three main categories. But I would like just to go briefly through this very simple case that we have to stress out quite simply the advantages of the digital tools that we have today. Well, most of the challenging cases will be in the aesthetic area, especially due to the fact that these are not forgiving areas. Every outcome that will be less than perfect will show. So when we see such a swelling in the buccal aspect of an anterior teeth, we already know what's the sequence of work that we are heading for. We know the challenges of reconstructing both the bone and the soft tissues, and that was already discussed in previous sessions by Isabella talking about the guided bone regeneration and David emphasizing the soft tissue consideration. So after having to go through all this trouble to reconstruct the tissues with predictable protocols, we move from here to here, and we can manage to have enough bone to finally install the implant. Now, that would be a good time to use our digital tools. We clearly see that the amount of the available bone that we have is probably suitable for a 13-millimeter implant. But when we illustrate such an implant on the long axis of the bone, we see that the screw opening is going to come out through the incisal edge. Now, again, it was widely discussed in previous sessions that we would like to plan the implant top down, and we would like to have a screw retained restoration rather than a cemented restoration. So in order to have that, we would like to slightly pull the head of the implant towards the palatal aspect. Now, if we simulate this palatal shift of the implant, you can see that this slight shiftment will end up with a buccal fenestration of the apical portion of the implant through the buccal bone. Now, that by this 2-second simulation, we can already understand that if we choose a shorter implant, we can avoid the intraoperative complications. Now, this complication you might think is quite rare, because usually we don't see these complications. It's going to be asymptomatic. But there was a very nice study done, published in 2018 by Chen. That group was checking immediate implant placement in cadavers, and they amazingly found that these complications happen in 25% of the cases. And as you can see in this CT image, this was a patient that came to the clinic with a request to have an implant in the lateral incisor where she had lost a tooth. She already had an implant in the central incisor, but it looks a little bit long. It a little bit invades the floor of the nose, but the real image is what we see in the 3D in the sagittal view. And as you can see, the implant goes all the way through the buccal bone, and I can assume that someone went through a lot of trouble to create a screw retained restoration in this case. Now, this was a totally asymptomatic case. So probably these situations happened quite a lot. Now, proper planning and the control of the drilling will also prevent such complications. This implant is way too apical and way too buccal to create an aesthetic restoration. This is an impossible case. Now, to correct this complication and to eventually end up with an aesthetic situation, and this is just halfway through the case, that would require several surgeries, or even there will be times where we need to remove the implant totally and start all over again. Now, in such cases, if we begin with the end in mind and we use the digital tools, again, like in this case, a very similar situation, we just illustrate the position of the implant with the axis of the bone, taking into consideration the biological complication, the biological environment, as well as the prothetic outline. Like a computer game, we can create very simply a virtual template that will direct our drill in the 3 dimensions to the proper position. We can print this virtual tool in a 3D printer to be used during surgery. And eventually we will end up in a very fast, predictable, and easy surgery that in this situation can even be flapless. And that means a lot also in terms of healing for the patient. So if we sum up the advantages of the use of the digital tools and the advanced technologies that we have, first and the most important will be the ability to better diagnose the case, to better simulate the case. It gives us, the digital arena gives us the comfortable environment to communicate between the treating team, even if the surgical and the prosthetic aspects are done by the same surgeon. And of course, if we're considering the use of surgical guides, that will be giving us the ability to perform better also in terms of treatment outcome. And that was also, we can connect that to the just asked then by Frank Renard that was talking exactly about this, reducing the human factor and reducing the intraoperative complications by previous simulation and previous proper preparations.
Exactly. So this is a very strong pitch for the benefits of digital, all the way from the diagnosis and planning through the surgery and even the outcomes. Yet, this is not the first time we talk about this topic. Not everybody is full on digital yet, right? A lot of people are still on the fence. What are holding them back? I mean, some experienced surgeons might say, well, I don't need all these fancy tools. I just know exactly where I place my implant.
Yes, definitely. It seems that we are, the more experienced the surgeon is, the more reluctant they are to adopt these technologies, because in a way you have to trust the guides, you work a little bit blindly. And when you are very used to trust your hands, let's call it, then you are quite reluctant to adopt these digital tools, the surgical guides. But as we very well known by this paper that was published in 2017, and that was just one among many that was checking and trying to evaluate the advantage of the guided tools. So you can see that they were examining very experienced clinicians with 10 years of experience in implant surgery, performing more than 300 implants per year. These are experienced clinicians. And again, this is just one paper among many that are showing that the guides are going to give also very experienced clinicians an advantage in terms of the position of the implant in parameters of implant shoulder, implant tip, and maybe most important in implant angle, because this is the most, the factor that influences the most the superstructure, the prosthetic outcome.
Exactly.
So for sure, and it's very important to stress this out already at the beginning of this evening, that these tools are not a replacement to your knowledge. It's not something to back up a lack of knowledge. These tools should be adopted by experienced clinicians to enhance our capabilities. And that's, Gerrit, basically the issue about digital aspects also in our everyday life, how it enhances our capabilities and not backing up a lack of something.
Exactly. Well, this was an important point also in our prime time debate in the EO Digital Days when we talked about digital implantology and how far we could go. Let me welcome a few of our audience members who just shouted out. Elani Pantelidou from Cyprus joining us, Michael Poyet joining us again. We have Sergio Satio from Brazil. So again, a truly global spread. We have Lucas Wa from Germany. Isabella's with us, sending us a first question. Brenda Mertens also joining. The baby is finally sleeping, she says. So before we continue, let's take Isabella's question straight away. If a young practitioner, because you just already pointed out, this is also an important tool in the hands of an experienced clinician. Isabella writes, if a young practitioner wants to start using digital tools for implant dentistry, what advice would you give where would you advise them to start? Is there anywhere, and I know you and I talked about, we'll get to the workflow in a little bit, or maybe we should do that now and then answer Isabella's question in the meantime.
I would just like to address the question because it's very important to also for young clinicians, let's call it, but also for the experienced clinicians, but the ones that are doing their first steps in guided surgery. There is a learning curve, like with any other tool that we adopt, with any other technology that we adopt, with any other technique that we adopt. So my advice is to start with a very simple case, a case that you can control even if something goes wrong when you are adopting the technology. Because first of all, the case should be, your first case should be done to get familiar with the workflow, which we will be talking in a few seconds. But that would be to start with one very simple case of maybe one missing premolar upper arch in between two teeth, where you have plenty of bone, which means that you have a wide envelope of to cover up for mistakes if you had any during the workflow.
Exactly, and that's very practical tip, and not save the digital stuff for the more complex things, but actually start in the more simple cases to get started with. You just referred to the study which talked about the outcomes and the predicted accuracy and predictability. What kind of numbers can we expect there? Can you show us any of the differences that we can expect?
Yes, well. I would like to show these two studies and a little bit of numbers of what we can expect in terms of accuracy. And you see that the mean numbers that were tested, both these review papers, especially the one by Tali Chackartchi that was taking 24 studies, more than 1,500 implants, you see that the mean deviation between planning and the final outcome is quite acceptable. We can expect 1 millimeter deviation in the entry point, around 1.4 millimeter deviation in the apical part, around 5 degrees of angulation deviation between planning and execution. But Gerrit, the most important numbers in these studies, in the case reports, in the systematic reviews, in the case series, the most important numbers are the ones in the brackets, because the ones in the brackets tells us the range of mistake, not just the mean accuracy. And if you look at the numbers in the brackets, you see that sometimes the maximum deviation can be of 4.5 millimeters in the entry point. That means that you are actually jumping outside the bone envelope once you are using a guide. So these are exactly the cases when someone says, my God, I can do much better freehand. Why do I need the guides for? So when we have such a problem, when we have such a deviation, it means that we had a problem in calibration. It means that we had a problem during the workflow. And when I speak about calibration, I mean like when you drive your car and you use your GPS system and it tells you that you are driving in a certain lane, but actually you are driving on a parallel lane, then this means that you have a problem of calibration. The same thing goes for guided surgery. The most important part for us to be as close, as precise to the numbers in the mean and to reduce the deviation, the numbers in the brackets, will be to follow the workflow and to make sure that we are calibrated when we go from the physical world to the screen of the computer, to the digital arena, and when we go back to our physical world. These are the 2 points of calibration where we have to be really careful. And if we miss something there, then we might have a problem with the end result.
Exactly, and I think it's important that we understand that these numbers that you mean is a study about the difference between the planned position and the actual outcome, right? This is not
Exactly, yes.
comparing digital or guided surgery versus freehand, because we briefly touched on that with Enrich, that is already a huge improvement. But this is still obviously something we need to be aware of, and you say calibration is key.
Yes, definitely. We are talking about the need for calibration in order to be precise between what we planned and what we eventually going to get in the surgical field.
Yeah, yeah. And I guess, I mean, these are outrageous numbers, 4.5 millimeters, but you would
Yeah.
see that immediately as soon as you put a guide in which is 4.5 millimeters off, right? I mean, you would never drill.
Not always, Gerrit, because some of the cases are done flapless. Some of the cases are done with the guide covering the whole ridge. So just after you finish drilling, you will realize that there's a catastrophe. And sometimes even if the deviation is 2 millimeters and not 4 millimeters, that's a lot.
Yeah,
So you will not always distinguish that during the process. One of the things that we need to stress out during the workflow is to uh, put some points in which you can control the calibration, in which you can check your calibration to see if until now we are on solid grounds, and until now we are close to what we planned, to try to figure out if we are on the right track, not just at the end point.
exactly. Well, this is very much in line of a question that Frank Renoir himself is just sending in, like, great metaphor. How do you know when you are not in the good line? And I think next up, and then we come to the end of the part we prepared, is please show us the different steps in the workflows, and perhaps with this question in mind, and show us how we can make sure that our calibration is still aligned, or where we can prevent or correct potential errors.
Of course, yes. So when we are talking about the whole workflow from planning to execution, we need to understand that every part of this workflow is important. Every part of this workflow is going to influence the end result, meaning starting with data acquisition, which is a very important part, going through the planning in order to get eventually to a very accurate result in the surgery. So to go through all these steps of the workflow, I would like to share with you briefly a case.
Mm-hmm.
This patient had a trauma several years back, and now he came to our clinic after diagnosed with external resorption in both central incisors. So our plan was to extract the two central incisors and to augment the tissues and restore the missing teeth with the implants. First, we extracted the two central incisors, and while waiting 6 weeks for the soft tissue healing, we took the time to create the digital file and plan implant placement. The data acquisition is very, very, very important to be done accurately, since it will influence tremendously the end result when we are talking about the use of a guide. We first need to have the three-dimensional view of the patient. That will be the CT scan, and that will be acquired as a DICOM file, later on being uploaded on the software. The second piece of information is going to be the impression of the mouth of the patient. That will be either taking with an intraoral scanner or with just conventional impression, later on being scanned to an STL file, a digital file. And the third piece of information that we need for our planning, that will be the wax-up, the destination, where we would like to end up with the prothetic outline of the restoration, the future restoration. Now, once we had these three components, we will upload everything on the software and we can simulate the case. Now, this is just like a computer game. We can plan the implant position according to the available bone, according to the future restoration. And now you can see clearly why it's very important to have a very exact impression, a very accurate wax up, not just approximation, but the exact position of the outline of the future restoration if we want our implant to be planned according to it in the perfect angulation. Now, once the implants are in position, we can virtually design a template, and that will be eventually the guide. That will guide our drills into position once we go to the surgery. And this virtual template is going to be printed in a 3D printer to become a physical tool to be used during surgery.
Now, and Tali, do you design this guide, or does the software, just based on where you want to place the implant, automatically generate the model for the 3D printer for the guide?
It depends on the software. Some softwares create first an approximation or a suggestion for a guide, but eventually also in these softwares you control it freehand. But I prefer the options by which you totally design the guide by yourself, because then you can suit the shape of the guide to your surgical plan. And you can design where you want the guide to be more distant from the tissues, where you want to elevate it flap, where you want the tissue stop. That will be taking into consideration your surgical plan and not being in the way while you make the surgery. Now, the first step, Gerrit, for validation of the calibration will be when we check the guide in the patient's mouth. If we check the guide in the patient's mouth, we expect a positive sit. We expect it to be perfectly matching the teeth. Sometimes it's not perfectly matching. We have just a slight rocking of the guide. And this is a big, big red light. Under no circumstances, don't balance your guide, because sometimes we are tempted to say, well, there's just a small point here. If I'll grind it a little bit, the guide will sit perfectly. But this is exactly a very important sign for us to know that we have a problem in calibration. Usually it means that we have a problem in data registration, in the impression taking, and we need to go back to impression taking. But this is a very important step to begin with. So I usually suggest not to make the check of the guide at the same day of surgery. Just make a 5-minute appointment, not with everything ready and the whole day cleared out for the surgery. Just make a 5-minute appointment, check the guide, see if it fits okay, and just then continue with your with the surgery. Now, once we start working, you can see that I use an open guide. This means that it doesn't cover the ridges. That will be a second point in which I can check my calibration. I can peek underneath the guide and see if where the drill is perforating the bone. And this is another validation for me to see if it's the same as I planned it on the software digitally. So this is again a very important stage for me. So I prefer to design the guide very open and very minimal in the area where I work. And eventually, after all the drilling and preparation, we take a full advantage of the guide and we insert the implant through the guide. I know that there are surgeons that are doing the whole sequence of drilling through the guide, but for the implant insertion, they do it freehand. They take off the guide and then they insert the implant freehand. Now, we try to be scientifically based, and we know by several papers that when we are performing a fully guided protocol, meaning inserting the implant also through the guide, we are going to be more accurate than as if we did just the drilling and inserted the implant freehand. And this will have an influence, especially on implant angulation. Again, a very important parameter if we want to end up with a screw retained restoration. Eventually, if we go through the whole process of work with proper attention, with meticulous work through all the steps of work, we can be predictable, keeping in mind that every step of the way has a potential error that eventually is going to be cumulative in the end result. And now we can continue with bone augmentation, but that's another story already discussed by Isabella. And we can also take advantage of the guide after healing for uncovering of the implants to make it minimal and finalize it.
Do you use the same guide again, or do we need to reprint it?
I just use the same guide. It waits through the whole process of healing. And then I just use it to know where the heads of the implant to make a minimal opening and to finalize it like this.
Wow, clear explanation, I think. Thank you for sharing that. There's a few questions coming in. I'm just going to acknowledge Jacob Eckstein's question, because he'd like to know more about the full arch restoration, but maybe we get to that in a little bit. I first want to take Christina Ivancheva's question. She's just asking, while you were telling about this, what is your opinion about using only a prosthetic guide? Well, what are the pros and cons?
Yes, a prosthetic guide, we should always remember that it is not taking into consideration the shape of the bone, the position of the bone. And there are many situations, especially when we work in the posterior mandible, where we don't have the bone where we want the implants to be. So if we just make a prosthetic guide who doesn't take into consideration the shape of the bone, there will be many occasions where we put the guide, we see that it's totally not in place where we have the bone, and we will just put it aside after someone went through a lot of trouble to prepare it. So I think that today, since the digital tools are so accessible and so cheap, and we can take advantage of that, even just for the diagnosis, for the planning, even if we don't eventually end up with a printed guide.
Exactly. Well, very, very clear. Let me invite everyone who is just joining us. We are talking tonight with Tali Chackartchi about digital implant surgery planning and guided surgery. And if you have any questions, please make use of the fact that we are live. Send in your questions via the live chat, and I will relay them on your behalf. Now, as I said, Jacob Eckstein sent a question. He's first of all saying, great presentation, two exclamation marks. So thank you, Jacob. Can you please elaborate regarding the possibility to use the guided stand in a case of a full arch reconstruction using a bone-supported surgical stand? And please start at the beginning. What is the difference with the procedure that you just explained?
Okay, so let me share my screen again.
Yes.
Okay, when we are talking about full arch cases, I assume that we are meaning the fully edentulous cases. Now, with the fully edentulous cases, these are more advanced cases. If we talked, Isabella asked about which are going to be the situations to begin with, this is not the case. Because in these cases of fully edentulous, we have more trouble to control the calibration. Because as you see with the picture, we have just soft tissue. We don't have rigid points of calibration. And the soft tissue is mobile and depressible. Again, we know from the literature, a very nice paper by Vacek from 2011, that the thicker the soft tissue is, the bigger the deviation we are going to have with the position of the guide. If we have 1 millimeter thickness of soft tissue, the deviation is going to be 0.4 buccolingually. So it's much more difficult to control the calibration. Now, another thing that I want to stress out, we are talking about the advantages of the digital tools, but they also can be very confusing, since it's all colorful and nice, but it can be deceiving. Like if you can see on the image of the CT and the illustration on the CT on the left picture, I can talk with a lot of confidence saying that I was planning the implant according to the superstructure, according to the anatomy of the bone and the limitations of the anatomy. But actually, how do I know that the outline of the prosthetic frame is correct? How do I know that this green illustration of a wax up is positioned correctly on the tissues? I don't have any reference points. So if we talk about the workflow, we have two interfaces that we need to control in terms of calibration. The first would be when we go from the patient, from the physical world to the software, and from the software to the patient. Now, in fully edentulous cases, we need to create points of calibration. And there are several methods. I will just go through it briefly. We can either use radio opaque markers on a denture that the patient would take. And we can also take, and this is my favorite method, we can use the soft tissues as reference points. If we make sure that the patient take a CT scan with air around the soft tissues, meaning with an open mouth, with the soft tissues reflected, then we can see the outline of the soft tissue, and we will have endless points of reference to superimpose the cast model or the impression of the patient, and eventually the wax up to properly plan the implants. And of course, the most predictable and stable thing that we can do is to shift a fully edentulous case, a soft tissue supported case, to an implant and soft tissue supported case by using provisional implants. And I would just relate again to the question of Jacob, asking about a bone supported guide, to say that we now prefer to have a tissue supported guide rather than a bone supported guide, because a bone supported guide would be less accurate. When we are using bone supported guide, we are counting on the CT scan, and that will be DICOM files, and the resolution of the DICOM files are at least 200 to 400 micrometers in the 3 dimensions. When we are leaning on soft tissues, or when we are supporting on the impression to create a guide, we are using STL files, and that would be an accuracy of 20, 25, 30 micrometers. That would be much more accurate to end up with. So today we try to improvise with a guide to do it soft tissue supported, or like in the lower picture case, an implant and tissue supported, and not a bone supported guide. Now, just
Tali, when you mentioned this is one thing I'm struggling with, because you started off that the main challenge, or one of the key challenges in the edentulous patient, is that the soft tissue is more flexible and impressible. So how do you balance that out with your favorite method of using the soft tissue as for your guide?
Good question, Gerrit. So thank you. So once we are leaning on the soft tissue, we need to be very careful. That is why these cases require a lot of experience. When we talk about numbers of accuracy, and I show the numbers from several systematic reviews talking about T-supported guides. So when we are talking about full edentulous cases, the numbers are less accurate. And the accuracy is going to be very much dependent on the proper positioning of the guide. Now, it takes a lot of experience, and it will require a very experienced clinician, both in the prosthetic side and in the surgical side, to take a proper impression of the soft tissues, to validate that the guide sits in a positive sit on the tissues, not pressuring differently between right or left, because otherwise we will have a deviation. But still, if we do that carefully and also drill passively through the guide without pressuring against the guide, then I would prefer leaning on the soft tissues than to be supported on the bone. That would give a more accurate result in my hands.
Yeah, but as you say, this can only be done by very experienced clinicians. Yeah.
Yes, but I think this is a learning curve, and if you start gradually with two supported cases, then just distal extension, and then just jump into the full edentulous cases, then it shouldn't be a problem. And I just wanted to finalize the point here with the need for calibration with the full edentulous cases, saying that when we move back from the software back to the patient's mouth, again, we need to make sure that we go back to the same place as we planned it on the software. We don't have any shift in the position of the guide when we go back to the patient's mouth. So again, the most predictable option would be the use of provisional implants, because these are rigid points that we can relate to. And we can also design the guide in a way that it will have tissue stops, like in the lower picture, it will have tissue stops in certain points that gives us the stability. But again, this will require a lot of experience by the treating team. Now, here before we go to the questions, I want to just say one thing about fixation pins. When we use guides in full edentulous cases, we use fixation pins. But when we look at the literature, you see that fixation pins not necessarily improve the result in terms of accuracy. We mistakenly think that fixation pins will improve the positioning of the guide. But then I would like to share with you this picture. What we see here is a patient just about to start surgery. This patient is going to go through surgery in the upper jaw. Now, the whole upper jaw has anesthesia. And now we insert the lower denture, and we insert the jig. And then we insert the guide on the upper arch. And now, and also our fingers are there in the way. Some of us has bigger fingers, some of us has thinner fingers. And now we ask the patient to close their mouth. Now, once they close their mouth, for sure, it's not going to be in the same muscle pressure as they did when they took the CT scan or when we planned the case. And only now we insert the fixation pins. So in this situation, we already insert the fixation pins after we had the deviation in position. And that is the reason why we don't see that fixation pins add accuracy to the position of the guide, add accuracy in terms of calibration. This is just a mean to stabilize the guide. This is not a mean for proper positioning of the guide, and we should remember that.
Great addition. Thanks for explaining this more advanced and complex situation of the edentulous patients. If you have any questions about digital surgery planning or guided surgery for Tali Chackartchi, please send them in via the live chat. Tali, I have a question. We talk a lot tonight about the benefits, the potential, how easy it all is. what are some of the risks of difficulties, complications, things we should be aware of when we work with a guided surgery like you are showing us tonight?
Well, I think that the most problematic thing will be, and that would be also the biggest complication, that would be if we have a problem in calibration. So we just need to make little points. Each case is different, and we need to make little points where we can check the accuracy and the calibration of the guide, and not just at the end point. So when we are going through the process step by step, and we go through the learning curve from an easy case to a more complex one, then I think we're going to be more on a solid ground.
Exactly. So calibration is one key point. Anything specific we should keep in mind when working with these guys during surgery?
Yes, definitely. This is true, especially for fully edentulous cases, but also for T-supported cases. Once we are drilling against the guide, one of the biggest deviation that we can create is by pressing the guide. Now, we are very stressed out. We are very focused on the procedure. So we push against the drills in order to make them go through the bone. Now, this is something that can create a deviation also in T-supported guide. And I think this is maybe the most frequent complication. This pressing against the guide can create also a breakage of the guide. And this is totally not a pleasant complication after you went through the whole process and explained to your patient how you are very advanced and technological and you are going to create a guide. So eventually, if you end up with a broken guide, then that will be a pity. So
How often does that happen in your? I mean, is this very rare, or is it so often that you order two guides just to be safe?
No. This is a very rare complication. I would say this is something that happens especially when you are just a beginner with this technology and you are not very well familiar with the fact that you should work passively. So you either get the tubes falling off during your drilling, since you drill with the extreme lateral deviations, or you just break the guide. But this is really an extreme complication. This is not very rare.
Okay, not very often. How about heat? We have a question from Chaim Wessler, I think. He says, great. And can you show what about the cooling system? Do you have any tips, please, on that?
Yes, this is a very frequent question because we're dealing with a bone. We don't want to overheat it. We less and less use internal cooling, mostly external cooling, especially if we use a guide that is covering the ridge, we might end up with overheating of the bone. But there were several studies that were checking that with different kinds of guide. And there's a common conclusion that if you are using a cooled solution, one that is just coming out of the refrigerator, then through the process of work, we can expect an elevation of just 1 degree in the temperature of the bone, even when we are working with the external cooling. But I would just want to make a small remark that every case is different. And of course, we need to relate to a specific case. If I would see that the bone is very hard and like a type 1 bone, from now and then I will take off the guide, I will just wash off the debris and maybe do some internal cooling and not just count on my knowledge that would be enough.
Exactly. So you look at the type of bone to determine what kind of cooling protocol you're using during the surgery.
Yes, but basically just using a cooled solution, that would be enough.
Would be sufficient. Yeah. I see a question from David Polak coming in, and I think he's referring to our previous talk on the edentulous case where you showed the implants for guidance. He says, does it matter where you place the provisional implants? Is there any tips or best location to do that?
Yes, let me just elaborate a little bit about the provisional implants. When we create, and I'll just go back to one of the pictures. When let's see this one.
Make sure you reshare your screen with us because I just took it down.
Oh, yes. Okay.
Let me, in the meantime, thank all our active participants for their questions tonight. This is what this is all about. Just ask. We are live. Send in your questions and we'll refer to it live and try to pull up pictures as we speak. Yes, Tali, there we are, back on the slide. Yeah.
Okay. So when we speak about the workflow, we want to put the provisional implants just before the patient does the CT scan. So then we will have the provisional implants in the CT image, and we can superimpose on that the impression of the patient and the wax up. Now, when we do that, it means that we insert the provisional implants freehand. It means that we might be close to anatomical structures. So we try just by a two-dimensional view of the patient, two-dimensional imaging, we try to locate an area that we will have sufficient bone. Usually we will prefer to insert at least 4 provisional implants, two at the anterior area and 2 at the posterior area. That will have 2 reasons. One, since the more implants we have, the more stable the guide will be. And the second is that usually, since we insert the implants in freehand, and usually in a bone which is very trabecular, if it's in the posterior area, it's usually a type 4 bone. If it's a lower mandible posterior area, we don't have a lot of height. So the provisional implant will be very small, very not so long. So between the time that the patient took the CT scan and the time of surgery, these provisional implants might fall, might disintegrate. So we want to have at least 4, and we try to insert the provisional implants very close to the surgery itself. So it means that we put the provisional, the patient go to the CT scan, and we try to make the surgery within 3-4 weeks to avoid the situation by which the provisional implants just disintegrate and fall out.
Perfect. Very, very clear explanation. Let me quickly take the follow-up question from Maria, and then I come back to the question of Kobi Landsberg and Lucas Wa. We're heating up on the questions part. Maria Margariti is now sending in. So when we put 2 provisional implants, and you just recommended 4, but okay, when we put 2 provisional implants to stabilize the guide, do we need any pins to the soft tissue? Is there a relation between the pins, which you already said it's not for accuracy, but just for fixating the guide, and yes, so, the 2?
I would try to avoid pins. And again, the provisional implants and the pins has 2 separate roles. The provisional implants are going to be positioned for calibration, to calibrate the impression of the patient and all the data acquisition on the software, and then to calibrate the guide in the patient's mouth. And the fixation pins are going to help us to immobilize the guide once we already drill. Now, I try to avoid fixation pins for 2 reasons. Once it's because it's in my way, and the second is because it might by itself make a deviation, especially if we use fixation screws and not fixation pins. If I have a possibility, I would prefer to have fixation in the vertical manner and not lateral, like you see here in this picture. In this picture, you see that the pins are going to come from buccal to lingual. When we insert the pins in a lateral way, we might make a deviation in the guide. We might press against the soft tissues, and that will make an error buccolingually, which has a bigger influence on the end result. If we are going to use fixations in the vertical manner, then the deviation will be less problematic. So one tip is, if you are able to, try to avoid fixation. A second tip, if you already use fixation, try to use pins and not screws. And if you use the fixation pins, just try to use it in the vertical aspect and not lateral.
Wow, we are receiving a lot of hands-on practical advice. Thank you so much, Tali. Earlier in this Just Ask, we talked a lot about the risk of calibration errors and that causing a lot of trouble and in the end a complicated outcome. Kobe Landsberg, you referred in that context to create a design where you can still have a visual view of the bone, create a design of your guide where you can still, if needed, open the flaps. Kobe Landsberg said, would you advise to take radiographs during drilling? And if so, how can you do that with a fixated surgical guide? So let's start with the first part of that question. How would you monitor during the surgery? Would you use radiographs?
Yes, if I have any doubt or if I need to check anything about position, of course I would take radiographs. Of course, if we are talking about fully edentulous cases, then the repeatability of going in and out with a guide in fully edentulous cases is a little bit tricky. If I'm positive with the positioning of the guide, I can take it in and out again. Again, we need to keep in mind that the fixation is just fixation. It's not for calibration. So again, I need to verify the calibration and only then refixate if I took it out. But usually I find myself taking x-rays during intraoperatively where the guides are not fully edentulous, just in cases that are T-supported, but there's no reason not to do it also in cases of fully edentulous.
Yeah, and just to be super clear, in a teeth-supported guide, you don't need to take it out. You can just take the
No, I can take it out, but it's
not
more
necessary.
Predictable to bring it back in place in the same calibration.
Exactly.
When we are in soft tissue guides or when we are on fully edentulous cases, then the calibration, when we go in and out back and forth, it's a little bit more tricky. So we need to be very meticulous about the insertion of the guide if we already took it out.
Exactly. Very clear. Now, here's a question from Lucas Wa, and I know you like this question. I mean, you already planted it with me, but it just came from Lucas. So thank you very much, Lucas. Because Lucas writes, besides improving the current possibilities of the digital workflow, what do you think are the future steps in guided implant surgery? And let's do guided first, and perhaps then show us a little bit more about what's possible in the future with digitalization.
Thank you, Lucas, for your question. Well, I will just go to this illustration and let me share my screen again.
Yes.
You see my screen?
Definitely.
Good. So again, let me go back to the main purpose of using these tools. We would like to enhance our capabilities and our abilities. And the one thing that is a little bit restricting now is that each time that we want to use such a digital tool, we have to go back to the computer screen. But luckily, we have great evolutions around us, also in our everyday life. The invasion of mixed reality and augmented reality is taking out the strings from the need to be attached to a computer screen. So we are able to project the digital image in our physical world instead of being constrained to the screen and then go back and in from the digital arena to the physical world. So this is just an illustration, but what it means is that eventually, with the use of augmented reality and mixed reality, we will be able to project the digital information that we need on the view in front of us, whatever we see in the computer screen. We can see the WhatsApp itself, not on the computer screen, but at the physical area where we work. And we might even have a stylus to direct us, a virtual stylus, to direct us to the pre-planning that we did on the software. So in my eyes, the biggest advantage of having the technologies mixed with our real world would be with the application of augmented reality. There are some medical devices that are already in use in spine surgery, in eye surgery. There are some groups that are working on augmented reality and mixed reality in implant surgery, and there are several publications about in vitro studies. And I'm sure that this is going to be the future for us. And if we speak about augmented reality, let me just elaborate with another technology, and that would be what you see on the screen now is the HoloLens 2 by Microsoft. HoloLens 2 is just a visor that is projecting augmented reality the same way as I showed in the illustration. But in this specific case, I was just playing around with it, trying to figure out the differences between the HoloLens 1 and 2. There are some advantages, but also some fallbacks. But the thing is that we can use this augmented reality also to communicate in a distance. I communicate with a colleague that can be even in a different country, especially important now in the COVID era. And what you see now on the screen is what my colleague is going to see. He sees exactly what I see. He sees that in real time, in a very good resolution. And he can comment, or I can use that as a teaching tool. I can use that as a tool to make consultations. So the digital technologies are really promising. They are more and more invading into our fields, into implant dentistry. We see now also artificial intelligence, that we see that in several applications in dentistry and implant surgery, also for diagnosis. You can upload your CT image on software, and it will give you all the remarks that you need about diagnosis and problems that you might have with a certain CT. So the future is promising, Gerrit.
Cool. So basically what you say, a big thing that will be coming into this digital implantology is the use of augmented reality. First, or on the one hand, as replacing the physical guides. We might be working with navigation, dynamic navigation, but then in front of our eyes. And the other application is also something I never heard of before, is where you use it much more to be in contact with colleagues, with experts for teaching, tutoring, mentoring, which is an exciting opportunity. It's a little bit further away from the digital planning, but could be very well be used to improve the outcomes, right? Which is
But
in the
Gerrit,
end the result.
you can also use that to communicate between the treating team. Instead of having a meeting, I have to travel to someone else's clinic to see a patient, to make a consultation. You can just use that to everyone sits at their offices, look at the same picture, just the patient is in one office, and with the ease and convenience of your office, you can see whatever the treating person sees, and you can make a live consultation without the need to be present in the same room.
Yeah, that is very exciting future. And how far away? Because you show you are experimenting with this, you are doing this. How long will it take before we see this in dentist clinics around the world, dentistry clinics around the world?
Well, the HoloLens is something already quite available, and it's in use in a lot of industries, whereas the augmented reality still is in development stages, since the tracking possibilities is something that in our field of implant surgery requires a lot of accuracy. We are talking about parts of a millimeter. So these things are in development, and I'm sure it will take several years, but it will invade both our everyday life and our professional work.
Exactly, and it's very good to know and exciting to see that you are very much on the forefront of these developments yourself. You're experimenting, you're doing it, so we should keep an eye on you and keep following you in the next few years.
So
With that,
just before we go to the maybe next question, I would just want to share one more innovation which I find extremely exciting. I don't know if you see my screen or not.
No, I stopped that so we could talk side by side.
Let me just share it again. This is a new development. It's not so new anymore. It was presented around a year ago. This is a breakthrough that was presented by Tel Aviv University scientists, and there was a parallel team that was working on that in Technion, Haifa University. And these scientists were printing in a 3D printer a live heart. Instead of ink, they were inserting into the printer live cells. So maybe the future of implant dentistry won't be the installation of implants, would be rather a creation of a tooth in a 3D printer and somehow implanting that. So yes, the future is promising.
Printing teeth, right? Well, that would be kind of a bomb under the implant dentistry field, but it's not that far yet. But it's good to keep an eye on these. Thank you so much. Well, instead of taking the next question, I'm also looking at the clock, Tali. We're nearing the end of our maximum of 75 minutes. So if there's no burning questions anymore, and I don't have any stack laying around, I'd just like to summarize some of the key tips that you shared with us tonight, where you clearly stated, please get started with digital and get started in a relatively simple case, right? This is not a replacement of knowledge and expertise, and you need to throw yourself on the learning curve and get started. I think that's very useful advice. And you warned us in several occasions, in several ways, about the risk of the cumulative errors of calibration, so that you need to be checking and rechecking all the time if you're still on the right check. And I love the little practical thing is that never balance out your guide, rather make an extra appointment of 5 minutes to fit the guide and make sure that that's in place before you get started. Very practical advice as well. So thank you with that. I hope in the future we have another Just Ask Together where we talk more about printing teeth and augmented reality applications. But for tonight, this is all we have in stock for you. So let me address our viewers before I say thank you to you, Tali. Is if you liked this, please make sure you hit subscribe now on the EEA YouTube channel, so you'll be the first to know when a new video comes out. And if you know anybody who might find it interesting to hear this story, to get these tips, please make sure you now copy the link to this YouTube video and share it inside your network. If you want more where this is coming from, of course, first of all, you could explore the EEO channel on YouTube and see all the other Just Asks and all the other video. But I once again invite you also to consider the EEO membership, because you then get access to the EEO online library, which has all the recordings of the EEO Digital Days, which has a lot of recorded sessions from previous congresses, which gives you access to the two important scientific journals. So if you are not yet a member of the EEO, you should consider after tonight. With that, Tali, I would really like to thank you for your time and knowledge and expertise tonight. I hope this was a good experience for you as well.
Yes, it was great, Gerrit. Thank you very much again for the invitation. I would just like to end up with a special thanks to all the people that are working with me on an everyday basis, because, you know, Gerrit, it's all about teamwork, and having an A team is what makes you a true professional. So I would like to thank my A team, my friends and colleagues that share with me the same passion, that push me every day to become better, and that I wish us all to keep on collaborating and hopefully see each other also face to face and not just in the virtual setting.
Yeah, right. It's very true. It is a team effort. It was a team effort between you and me tonight. It was a team
Definitely.
effort with all our viewers who submitted questions. So thank you all for doing that. And make sure you mark the first Monday of your month, because that's time for EEO Just Ask. And I hope to see you back at the next edition. See you then. Bye bye.
Bye bye. Thank you, Gerrit.